The human body has an extraordinary self-healing potential. Its self-defense and self-healing mechanisms help us to survive. Unfortunately, modern life, which promises a lot of comfort, carries a huge baggage of stress, which costs heavily on the human system. But the good news is that we can handle stress by adopting different ways of thinking, by changing our lifestyle, and by finding ways to unwind and relax. Welcome, ladies and gentlemen, to Dr. Tapaswini's Corner. That's me, and I work as a head and neck oncosurgeon at Fortis Hospital, Delhi. The evidence which links stress with ill health suffers from the chicken and egg problem. What came first, bad health or the stress, remains to be answered. But if we look at the cancers of the digestive system, there is ample evidence to suggest that it's a lifestyle disease. Throwing light on the issues of gastrointestinal cancers, especially colorectal cancer, we have with us Dr. Pradeep Jain. You are the director of Department of Gastrointestinal Oncosurgery, Laparoscopic GI, Hepatopancreatic Biliary and Minimal Access Surgery at the Fortis Hospital, Delhi. With more than 30 years of vast experience, you have great surgical expertise for laparoscopic GI cancer surgery, for complex liver, biliary, and pancreatic procedures, and also for performing bariatric or the weight reduction surgeries. Having trained yourself in advanced laparoscopic surgery for colorectal diseases from Dongguk University, South Korea, you have stood on various national and international platforms sharing your surgical expertise. Welcome, Dr. Pradeep. It's indeed a pleasure to have you on the show today.
Thank you, Dr. Tapaswini. I'm really happy to be in your show. Thank you so much, Dr. Tapaswini.
So if we look at the global statistics, the incidence of colorectal cancer seems to be really high in countries like Australia, New Zealand, Europe, North America, but it's low in countries like Africa and South Central Asia. So where does India figure in this picture?
Dr. Tapaswini, if you see the overall, India is lagging much behind than the other Western countries, like you said,
right,
in US, Australia, and the European countries.
Okay.
Our incidence of colorectal cancer is one of the lowest one. The incidence of colorectal cancers in US is approximately 40 to 50 cases in 100,000 cases per population. In India, it is somewhere between 4 to 5 cases per 100,000 population.
All right. So why is this geographical variance so stark? Or are these cancer predominantly impacted by diet or the environmental factors?
So this has been a combination of genetic factors as well as the environmental factors.
Okay.
In these countries which are having a low incidence of cancer in colorectal area, they have the pattern of diet is a bit different from those countries where it is high. Like we have a more of fibrous diet and less of a weight. We have our population is a low weight population. Maybe this is one of the important reasons.
Okay. So often, it is said with relevance to food. So what we are indeed what we eat. And so eat your food as your medicine. Otherwise, you'll have to eat medicine as your food. So there are a lot of diseases which are related to these unhealthy eating practices. Do we see an impact of age on these cancers?
Yes. Basically, these cancers, they occur more in patients who are above age of 50 years. As the age increases, the incidence of these colorectal cancers increase as the age goes up.
Okay.
So if the population which is having more of elderly people, the chance of having a high incidence of colorectal in those areas is very high.
Okay. Any gender variance do we see? It's more in males?
Gender variance is not too much. I mean, there is slight more prevalence of colorectal cancers in males as compared to females, but it's not a great difference.
So statistically, we don't see much of a difference.
Much of a difference, yes.
Okay. So in the past couple of decades, we have been seeing a rise in the life expectancy in the general population. And probably that's primarily because of increased access to the medical facilities and also the improvement in our medical care. So Do you think longevity has impacted the rising incidence of colorectal cancers?
Yes, definitely. The
Mm-hmm.
longevity has increased the incidence of colorectal
Okay,
cancers.
right.
Fully agree with that.
What about the socioeconomic strata? Is this something which is seen in the urban, in the people who are in the highest society or the highest strata? Has this got some impact with the socioeconomic condition?
Yeah, definitely there is an impact of socio-economical conditions. The people who are having in absolutely downside in the socio-economical strata, they're having
Hmm.
more number of cases of colorectal cancers as compared to higher up. Nearly about 20, the difference of 20%.
Okay, okay. But a strong correlation is seen with the body weight, obesity,
Yes.
and colorectal cancers. So, how do we explain this obesity to general public? You know, anybody with an increased weight obviously will not be defined. So, is this something to do with our BMIs? And when do you coin a patient to be obese or morbidly obese? How is it defined? So that we have our listeners who they should appreciate that controlling your body weight has a lot of impact on preventing a lot of diseases. So how would you explain it to them?
Actually, the obesity is calculated according to the body mass index. If the body
Right.
mass index is more than 30, it is
Okay.
called obesity. If it is more than 35 to 40, then it's called a morbid obesity. So once the
Hmm.
weight of the patient goes up, the BMI goes up, the
Right.
chances of getting a colorectal cancer is more. And the
Okay.
second thing is these patients, they have a more incidence of cancer, and also they are difficult to manage if they have this colorectal cancer. So
Okay.
the overall morbidity after the treatment is much more in obese people than the thinner people.
So you also, Dr. Pradeep, you do a lot of bariatric surgeries also. So performing these surgeries, uh, has it made an impact? Has it reduced the incidence of, does it help in reducing the incidence? And if it does, how much time does it take for that incidence to, or the risk to go down?
Some evidence in the literature which suggests that if you have a decrease in weight, significant decrease in weight after the bariatric surgery, so the
Right.
incidence of these colorectal cancers goes down. The effect is more seen after 5 to 6 years after the bariatric surgery, because
Okay.
after 5 to 6 years, overall the weight reduction is more than 70% of excess body weight, and the weight is
Hmm.
stabilized, so the incidence goes down by that
Okay.
time.
Okay. So how do these patients present to you in the clinics?
The most common presentation which we see in colorectal cancers is the pain abdomen and the
Hmm.
bleeding PR, blood in the
Okay.
stools. These are the most common presentations. The other presentations can be because of complications of colorectal cancers, which can be obstruction. If the patient goes into obstruction, they have a lot of pain in the
Hmm.
abdomen. There's a distension of abdomen, and there's altered bowel habits. The
All
people who
right.
have these cancers have change in the bowel habits, what they used
Hmm.
to have in normal time.
Hmm. But is it true that symptoms would mean that the disease is in advanced stage?
Yeah, the early cancers, most of the times, they don't produce any symptoms. When they
Okay.
advance to certain level, then they can have either problem because of they're causing obstruction in the gastrointestinal tract or they're bleeding into the gastrointestinal tract. These are the two
Okay.
reasons the patient presents
Hmm.
with the symptoms. And they
Okay.
are often present when the disease is slightly advanced.
That gives us a thought how important screening should be. Because as we say that most of the patients when they present with symptoms, they're already in an advanced stage, which means we're not able to pick up patients in the early stage. So what is the proportion of patients who actually are caught early in our Indian scenario?
In Indian scenarios, as you already told Dr. Tapaswini, that the
Mhm.
majority of these patients they come in later stage. So
Okay.
only 4 to 5% of the patients they come to us they are in stage one, and
Uh-huh.
15 to 16% of the patients they come in stage two, and
Hmm.
in stage three, 50%
Right.
of the patients, and 25% of the patients they come they are already in stage four. So the scenario
Right.
is bad in our kind of countries, whether there's poor socio-economic status,
Hmm.
the people who are presenting late, they're having less and less availability of specialists, and
Hmm.
there's no screening program.
Okay. So the other thing which I was very curious to know is when you have a cancer, of the right side of the large intestine and the cancer on the left side of the large intestine, is there a difference in the clinical presentation of our patients?
Yes, definitely. There's a
Uh-huh.
difference in the right-sided colon cancers and the left-sided. The right-sided cancers have a bit worse prognosis as compared to the left side because they arise from a flatter kind of lesions, and the overall
Okay.
genetic mutations are different in the left and the right side. And the sensitivity of the drugs are also
Uh-huh.
different in both the areas. And the
Okay.
presentation, the metastasis also different from both the areas. The left-sided colorectal cancers, they present with the metastasis in the lung and the liver, and the right
Mhm.
side is they present more into the peritoneal spread. So they have more disease in the intra-abdominal, the spread in the intra-abdominal area.
Okay. So if patients come to us walking to the OPD and are out and are asymptomatic, is it that it's only a screening endoscopy that we are able to help and pick them up? Is that one tool
Yes,
which help us to catch patients early without symptoms?
yes, definitely. The screening programs that do help in catching the
Mhm.
colorectal cancers early and as well as preventing the basically they help in preventing the development of colorectal cancers if the patient is having
Okay.
polyp, a small
Right.
growth in the abdomen which is and the colon which is not
Okay.
cancerous. So in the both
Okay.
the ways the screening helps. And there
Mhm.
are, if you want me to elaborate, so definitely the screening programs, they help in detecting the cancers early. And if we pick them up early, the overall, the mortality and the morbidity is less.
Correct. Correct. And that's the story true with all the cancers. How do we
Yes, yes.
investigate?
So there's a difference between whether the patient is having a average risk for colorectal cancers or a
Mhm.
high risk colorectal cancer. That is known by taking the history. The
Okay.
patients who have got average risk, these are the
Mhm.
patients in which the endoscopy or a stool test, which are the kind of screening tests, they are advised only after the age of 50 years.
Okay.
If person is willing to go for endoscopy right away, that is the best test in fact, and that should be done.
Mhm.
Then other tests are the stool test, like
Okay.
the GOAC occult stool for occult blood or FIT. That's a fecal immunochemical testing. These are
Okay.
tests which can be done at the
Mhm.
particular frequency if the patient is not willing for colonoscopy.
Right. So you just said that there are patients who would be in the high risk and patients in the low risk. So how do we classify who are the high risk patients? I think our listeners should know so that they are more cautioned
Yes,
about it. They should go in for a screening program. So please detail
yes.
us as to who are the high risk
The
group.
the people who are at high risk are the people who have already got evidence of advanced polyp in their colon, or they
Okay.
have had a colorectal cancer in the past. People
Right.
who are belonging to the families in which the colorectal cancer is common, or the
Okay.
patient who's having a very immediate relative of there
Mm-hmm.
is having a
Mm-hmm.
colorectal cancer. The people who
Correct.
have received radiation therapy in the
Okay.
early childhood cancers, or the
Oh,
people who have had inflammatory bowel disease like the ulcerative colitis or Crohn's disease, they're high risk
mm-hmm.
patients for colorectal cancers. So these are
Oh,
the people for high risk. They should be having a screening at the early age and with a higher frequency as compared to people who got average risk.
okay, okay. So, Dr. Pradeep, we were talking about the investigations that we order for our patients. Is there any role of tumor markers that we do for even other cancers? Yeah.
No, the tumor markers cannot be considered. Tumor markers are not diagnostic tests. They are
Okay.
basically for the prognosis or
All
to
right.
see the tumor load in the body. They cannot be considered as a screening tool because there are a lot
Okay.
of ambiguity in the levels and ambiguity. Whether they're present or absent, that cannot determine whether the patient is having cancer or not. So they
Okay.
cannot be considered as screening tests.
So, but then if we have a patient with cancer, colorectal cancer diagnosed, so the tumor markers help us, as you said, it helps us to define the volume of the disease which the individual has.
Yes, yes.
And also, do we use it as, to in the follow-up protocols to figure it out
Yes.
as to how the patient is going to fare up in the future, or what is his disease status? Do we have some list of markers which we are using routinely?
In colorectal cancers, one marker most often used is CEA, carcinoembryonic
Okay.
antigen. It is
Okay.
basically done in all the cases preoperatively. We measure these markers in the postoperative period also, just to see the
Okay.
response. If they have a higher level of CA, and then after the surgery they have a decreased level or normal level of CA, that means, I mean, it's almost okay that that patient has undergone a curative surgery. And
All right.
these markers we follow up in the postoperative period. Whenever we call the patient after every 3 months, we measure
Okay.
these tests also, these markers also done, just to
Mm-hmm.
see whether there is an increase in markers again or not. If there is an
Okay.
increase in the marker, then there may be a suggestion that the patient is having recurrence of the tumor, and then we
Correct.
order a test accordingly.
So, so if we simplify it, the tumor markers help us to tell us about the status of the patient post treatment as to how he has fared up. Secondly, it will also help us to prognosticate as to how his future would be following the treatment and post treatment. Correct. So, what about the treatment protocols? What sort of a treatment do we offer to our patients early and in advance?
In colorectal cancers, the treatment protocol depends on the stage of the patient. By
Right.
doing certain tests like MRI, CT, or PET, whenever required, after doing
Mm-hmm.
those tests, we have to determine the patient is which stage the patient is in. Like if the patient is in stage 1, then we can go for upfront surgeries.
Okay.
But in stage, if you're talking about the rectal cancers, if the patient is beyond stage 1, in
Right.
those cases, there is a role of neoadjuvant chemoradiation. That means
Okay.
chemotherapy and radiotherapy done to downstage the tumor, and then we take
Uh-huh.
up the patient for surgery after waiting for 6 weeks.
Okay.
Because after doing downstaging the tumor, if we do surgery, the chance of local recurrence is less, and overall
Mm-hmm.
there is impact on the survival also.
All right. Right. What about radiation? Do we incorporate
He,
radiation in?
yes, in rectal cancers, we
Okay.
incorporate radiation. We're talking about chemoradiation. That
All
means there's
right.
a combination of chemotherapy and radiotherapy before surgery.
Okay. So, if you look at the times we have advanced in technology also, and there's laparoscope, as you say, you are a master of laparoscope, you have robotic surgeries. How have these surgical, technological advancements actually impacted our surgical results?
The technology, like we're talking about laparoscopy or a robotic, they
Correct.
help us in reducing the stress of surgery on the patient.
Okay.
Because during these minimally invasive surgeries, we have
Uh-huh.
lesser blood loss, we have a wider magnification, so our kind of dissection is much better. And in the
Okay.
post-operative period also, the recovery of the patient is much faster as compared to
Mm.
open surgeries. There's
Oh,
less pain, early mobilization, and
uh-huh.
patient can be discharged early, and
Right.
patient goes back to the work much early as compared to the open surgery. Whether you do
Okay.
open surgery or a laparoscopy, the results of cancer is same.
Okay. So it's primarily reducing the morbidity of these surgical
Morbidities.
procedures. Right. There are certain complications that we explain to our patients. So, what little would we like to tell what possibly could be the complications post surgery?
The most important complication post surgery in colorectal cancers is
Right.
the chance of leak. The leak
Okay.
is the most morbid complication, though it is not seen very often. But this is
Mm-hmm.
the most important complication which we should be aware of, and we should be ready to tackle those complications if they occur. And there are certain
Uh-huh.
risk factors which can lead to increase in chance of leak of the anastomosis. So
Okay.
there are certain group of patients we have to calculate the risk pre-operatively. If the
Correct.
patient is having too much of factors which are, putting the patient on the risk of leak. So these are
Right.
the patients in which we explain them in advance, and we
Okay.
take all the possible care, all the possible intervention before surgery we have to do to decrease the
Mm-hmm.
chances of leak.
Okay. Okay. So, after the surgery, patients are put on colostomy bags. uh, how is the thought of the stool coming out through a different passage, having a bag, and I mean, how does that impact the psyche of our patients?
Number one, the need of colostomy these days is not that great.
Okay.
After doing a colonic surgery, most of the times we don't need a colostomy, whether it's permanent or a temporary. But in
Okay.
case of cancers of rectum,
Right.
some of the patients of the rectum who are there where the growth is in the lower part of the rectum, in only in
Mm-hmm.
those cases, sometimes we require need of temporary colostomy. And
Okay.
the permanent colostomy is very, very rare. I mean, if the
Uh-huh.
patient's having cancer at the absolutely lower end of the rectum, only then in those cases, we have to give a permanent colostomy to these patients. And
Mm-hmm.
nowadays, because of availability of very good colostomy bags, the
Correct.
managing colostomy is not a great thing. I mean,
Okay.
if the patient is psychologically strong, he can very
Right.
well take care of the colostomy. We have patients who have
Okay.
undergone permanent colostomy or a temporary colostomy. They are able to even swim. They are able to play games, and they can just go everywhere without even people knowing that they are having colostomy.
That's wonderful. So, if we look at the quality of life of our patients post these
It is
surgeries,
not hampered that much.
it's not
It is not
hampered.
hampered.
That's a good news
It's more
for
of a
us.
psychological thing.
Yeah. And then when we counsel them about the treatment profile and the results, I don't think little bit of problems which they have to handle, which comes on the way, it would be of any major concern to them. It's primarily how we counsel them. Are there certain non-cancer conditions which call in for a removal of the intestines and all?
Yes, there are
Uh-huh.
conditions like inflammatory bowel disease who are
Okay.
long lasting, that they're
Okay.
there for a longer time and not responding to the medical management, or conditions like diverticulitis, which has led to leakage of the diverticular leak, and the patients are presenting with benign strictures. There's some obstruction in the colon which cannot be tackled by an endoscopic measure. These are the patients in which the requirement of colon removal is there.
Okay. So now coming back to the topic on colorectal cancers, having the patient having gone through the entire therapy, chemotherapy, radiation, and surgery, what is the treatment outcome like?
The outcome of the colorectal cancers after surgery and the chemoradiation combined, or a chemotherapy
Mm-hmm.
with the surgery, it depends on the stage.
Okay.
The stage, if the patient has presented in an early stage, the chance of survival is very high. If the patient present in stage 1, the chances
Mm-hmm.
of getting a cure is up to 90 to 95% of the patients.
Uh-huh.
And in
Right.
stage 2, it is somewhere around 80 to 85%. In stage 3, it's somewhere around 70%. And even in stage 4 of colorectal cancers, the overall 5-year survival or a cure rate is somewhere between 5 to 10%. In countries like US, if you consider all the stages, somewhere around 60% of the patients they get cured. In
Mm-hmm.
countries like us, even in countries like us, where
Right.
everything is not as rosy as in US, the
Okay.
overall 5-year survival rate, a cure rate is nearly 40% if you consider all the stages combined.
Okay. Correct. So, when we talked about the clinical presentation, we said most of these patients are asymptomatic and they are caught on a
Yes.
routine sort of an examination. So we're coming back to this question, how important is screening?
To decrease the mortality or decrease the death rate of colorectal cancers, I think screening is a paramount importance. It is
Correct.
very, very important because it led to the early detection of cancer. So if you do a proper screening, then the chance of getting these cancers stage 1 is very high. And number
Mm-hmm.
one, sometimes even if the patient does not have a cancer, they have just a precancerous lesion like polyps, adenomatous polyps. If we
Right.
detect those at that time only, we remove these polyps and the patient does not develop a cancer. So by
Mm-hmm.
both these things, we can definitely reduce the mortality of the colorectal cancers. So the
Okay.
screening is very, very important, I would say.
All right. Right. So is there a particular protocol that we follow?
In India, we are not following, but definitely there are a lot of screening programs running in different
Mm-hmm.
countries. As I said, the screening starts at the age of 50 years when in a
Okay.
normal, I mean, a patient's of average risk. But
Mm-hmm.
if the patient is having a higher risk, like there are different
Right.
groups in which the risk is more, in those
Mm-hmm.
patients, the screening and the frequency of screening depends on the type of risk factor you have. So
Correct.
if we are doing it for an average risk patient, we do it at 50 years, then we repeat this test, the colonoscopy, after every 10 years. But
Okay.
if the patient is having, yes, if the patient is having some the genetic syndromes, hereditary genetic syndromes, in those
Correct.
patients, we start screening at a much earlier age group, like in familial adenomatous coli and the patients who are having Lynch syndromes. These are the patients in which we start screening at the age of 25 to 30 years.
Mm-hmm. So what is this proportion of colorectal cancers which is hereditary?
If you see the hereditary syndromes, only 5 to 6% of the patients they belong to these hereditary syndromes.
Okay.
But up to 10% of the patients, 10 to 15% of the patients, they may be having some kind of genetic mutations, but they're not lying into these genetic hereditary syndromes. More than 80% of the patients, they are just sporadic. They don't have any kind of genetic mutation or any risk factor or any.
So, I mean, if I'm made to understand, a lot of these colorectal cancers can be prevented. In fact, it's a highly preventable cancer. So, what are the protective factors in this particular cancer? What would you like to tell our listeners?
The colorectal cancers can be prevented by just having a lifestyle modification, the screening. We have talked about
Correct.
screening, now about the lifestyle modifications.
Mm-hmm.
We have to have something in our diet. We should prevent a high calorie diet. We should take more of a protein, but not red meats, because
Okay.
red meat has been responsible in some studies to increase the incidence of CRC. And
Mm-hmm.
overall, if you increase the fibers in your diet, the chances of lowering colorectal cancers. And there are certain things like you have to avoid smoking, you have to avoid alcohol. And if you are diabetic, take care of your diabetes well. It should be tight control. And the weight should be in control. Your BMI should be less than 30. It should not be
Right.
morbidly obese or obese person. So if you take care of these things, the chances
Right.
of lowering colorectal cancer is there. And there are other things like you have a more of folic acid in your diet, and you
Mm-hmm.
have a lot of fruits. Studies say that the vitamin C use and the calcium use can also decrease the chances of colorectal cancers, but they're not substantiated. These are the general recommendations which one can
Okay.
give to decrease the chances of colorectal cancers.
Okay. So before we wind up, there are some myths which I would love that you clear for our listeners. One, it says having polyps means I have cancer and I need surgery. How would
No,
you
I
say
mean,
this?
majority of the polyps you will see, they are not cancerous because
Okay.
the incidence of hyperplastic, they're kind of benign polyps. If they are present, they're removed, no chance of cancer. Even in other kind of precancerous lesions like adenomatous polyps,
Right.
they are also precancerous. They're not cancers because it
Okay.
takes 10 years for
Mm-hmm.
adenomatous polyp to develop into a cancer. So if
Okay.
they are removed in colonoscopic by doing a colonoscopy, then you don't have any chance of getting a cancer. So polyp is not a cancerous, it's a precancerous if it is adenomatous polyp.
Okay. The second myth is screening is only necessary for individuals who have symptoms.
No, it's absolutely wrong because screening is always done in a asymptomatic patients.
Okay.
Because if the comprehensive screening program is always in asymptomatic patients. Symptomatic patients is only called as an opportunistic screening program. So majority of the screening is done in asymptomatic patients, and
Correct.
there is no need to have symptoms. You just go for a screening if you're about 50 years.
Okay. And the last is says colorectal cancer is fatal.
No, it's not fatal. In fact, I told earlier, if you combine all the stages, even in country like ours, the 40% survival rate is there. So the fatality depends on the stage. If you catch
Okay.
them early, almost all are curative. Almost all are curative in stage one. As I said, it is 90 to 95% cure rate. So
Mm-hmm.
they're not fatal. Even in stage two or stage three colorectal cancers, the survival rate is nearly 70 to 80%. So they're not fatal. If
Right.
you go to a proper person, go proper specialist, and get all the tests done and be aware, it is curable.
Thank you so much. Thank you so much, Dr. Pradeep, for giving us such beautiful information on colorectal cancers. Thank you once again for being on this show today.
Thank you so much, Dr. Tapasni. I really loved it and I felt very honored to be on your show. Thank you so
Thank you
much.
once again. The kite gives us a wonderful message. Fly high, but stay connected to your roots. In fact, the more we move away from Mother Nature in the name of modernization, we invite troubles. So strike a work-life balance, eat healthy, think positive, remain stress-free. Tips to harness body's natural healing powers. Thank you once again. Thank you, Dr. Pradeep. Thank you to all the listeners. See you next week with another expert on another cancer. Till then, goodbye.
Thank you so much.